Okay, I guess we will start. Good evening, everyone. Respected Dr. Viresh sir, members of the IADPE, and dear doctors. So, we welcome you back for another episode of Learn from Our Master series organized by the IADPE. And yes, crossing 50 webinars is definitely an amazing ride so far. And I thank all the doctors who are attending our webinars and other platforms like our Instagram and our Facebook. And we are very humble to see your positive feedbacks. So for those who are attending our webinars for the first time today, we would like to give a little bit of introduction about ourselves. So we are the International Association for Dental Practice Excellence, a dental platform in which we believe quality education always ensure predictable outcomes for dentists of all disciplines and abilities. Our organization is established based on the fact that the dentistry is complex and requires ongoing learning experience. So we conduct various webinars and workshops to enhance the skills of dental professionals and guide their dental journey. So without further ado, let us start our series episode in which our topic of discussion is the advanced protocols in endodontic retreatment given by Dr. Viresh sir. To speak a few words about Viresh sir, Dr. Viresh Chopra completed his MDS in conservative dentistry and endodontics from Subhati Dental College, and he is currently a faculty in Oman Dental College, Muscat. He is a key opinion speaker for FKG and Colteen and also conducted many lectures and publications in the field of endodontics. He is also a Style Italiano speaker and is a member of the American Association of Endodontics, Oman Dental Society, Federation of Operative Dentistry of India, Indian Endodontic Society, Academy of Oral Implantology of India, Academy of Operative Dentistry, and Academy of Aesthetic and Cosmetic Dentistry of India. So without wasting more time, I would like to invite Dr. Viresh sir for today's discussion. Sir, please.
Hi guys, thank you, Mr. Shanu, for inviting me over on this platform. I hope I am audible.
Yes, sir. You're audible, sir.
Okay, I would then straight away, without wasting any time, I would like to share my screen
Yes, sir.
to start the webinar. And here it is. So first of all, thank you so much, Dr. Shanu, for inviting me over on this platform to share my little bit of thoughts on the uh, this topic in endodontics, which is really close to my heart. Just a second. Just a second. Slipped my laptop slipped. Am I audible?
Yes, sir. Yes, sir.
Sorry, my laptop has slipped there. So it's just this topic is really close to my heart, and I really like working on that. So this topic is basically retreatment in endodontics. And this is Viresh in front of you, and these are my affiliations throughout wherever I work. I completed my BDS and MDS from Subharti Dental College in Meerut. I am currently pursuing my PhD from Bart's London School of Dentistry and Medicine in Queen Mary University. And I am the course lead for endodontology in Oman Dental College. I've also been privileged to edit two books on clinical atlas on retreatment in endodontics and bioceramics in endodontics. So if any of you are interested in seeing some clinical cases, how they are done, then you can go through these books and definitely you all will relate to the cases that you do in day-to-day practice in retreatment as well as in endodontics. And these books basically They comprise of cases from all the clinicians throughout the world. They have some of the famous clinicians in the world. The cases are there in this book. So probably if you like them, I'm also privileged to be and honored to be a certified silver member of one of the most famous online groups, which is called as Style Italiano Endodontics. So, people who are listening to me, I would definitely encourage you all to join this group. This is totally free of cost. It's an online group. But the beauty of this group is that it shows so many clinical cases from very famous clinicians and odontists around the world that we relate and we learn step-to-step procedures by seeing those cases. But yes, we need to be smart enough to understand which is the correct procedure and which is not the correct procedure to be done. Now, talking about the topic which I'll be presenting, it is basically retreatment in endodontics. And as I said, this topic is really close to my heart because I really like working on retreatment and seeing that what are the various causes that can fail the primary endodontic treatment in any teeth we are doing endodontic on. So what is the basic aim of presenting this webinar and presenting this topic? The aim of presenting this webinar is not to tell you all that how retreatment should be done or not to tell you all what is written in the books. Everything is written in the books. But the basic aim of the presentation here is to give some insights and little bit try to change the bent of mind how we look at retreatment. So first is we should basic aims are the we should analyze that what can cause the failures, then how to inspect the tooth, whether the prognosis of the tooth is nice or not, then to see that mishaps basically are not the end, because when we are talking about retreatment, definitely there is some kind of mishap because of which the primary endodontic treatment has failed, right? So we just need to understand that mishaps are not the end, and we will see through this presentation that what do I mean to say when I say mishaps are not the end. And when we are able to take care of these mishaps, we are able to successfully treat these teeth which are failing in the root canal treatment. But before I start, I want you all to understand this point that nothing is possible in the presence of microorganisms, but everything is possible in the absence of microorganisms. This means that if there is a quantity of microorganisms present at the site of infection or at the site of treatment, then it will never allow your wound or body to heal. However, if we are able to take care of the microorganisms in that area and create a sterile environment, then definitely healing is possible. Now, when I say that everything is possible in the absence of microorganisms, this does not mean that we have to completely or 100% eradicate microorganisms. We cannot do that. Nobody can do that. But what we are trying to do is we are trying to bring the quantity of microorganisms to such a small level or low level where your body defense cells or body defense mechanism can take over and finish off the healing mechanism and give success to the tooth. So this, please understand that what we are aiming at is we are aiming at bringing the quantity of microorganisms very low so that we are able to initiate the healing mechanism. We have lot of evidence which shows different factors which can lead to retreatment in endodontics, which can be operator skill, inadequate lateral condensation, knowledge, reading the radiograph, using wrong instruments. And you will see that all these factors are interrelated to each other. One will cause the other. But another major factor that has changed the game of endodontics is magnification. When we use magnification, lot of things change. And by magnification, I don't mean to say that we have to use only microscope. We can also start with loops from somewhere. At least something is better than nothing. So I would encourage all of you to invest a little bit. Whoever are using magnification, really nice. But whoever are wanting to use magnification, you can start from loops and at least have a clear view in excess cavities at least, right? If not in the root canal system. Again, we have a lot of evidence which shows that what are the various causes that can cause failure in endodontics and which are in front of your screens. Leaky canals, which means under obturations, over obturations, bad lateral condensations, or one of the major causes is missed canal, more especially in maxillary molars where MB2 is very often found these days. And these days, they say around 90% of the maxillary molars have MB2 canals. Now, this is some term which which is relatable to all of us, but I will not be talking about opium here. Basically, these are the factors that lead to failure of primary root canal treatment: over obturations, perforations, instrument fractures, under obturation, and missed canal. So this is the list of factors that basically form an umbrella and causes failure in endodontic treatment. Now, how do they cause failure? They basically cause failure by not allowing us to adequately clean and disinfect the root canal system. Right. So if an instrument fractures, what happens is we are not able to clean and disinfect the part of root canal which is apical to instrument fracture or within that instrument fracture. However, if we take out the instrument, we are able to do that. If there is a perforation, we are not able to treat because bleeding is there, microorganisms are there. But if we seal the perforation, we are able to do that. So what happens is it is basically not these factors that cause failures. Actually, failure is caused by inadequate cleaning and disinfection, which causes an increase in microorganisms. So it would be right to say that failures are caused by inadequate cleaning and disinfection and not by directly these factors. There is a subtle difference between what I am saying and what we have always read. Right. So if we are able to take care of these factors, or if anybody knows how to do a perforation repair and you are able to repair the perforation, then probably it will be very easy for us to retreat the tooth. Now, one thing we need to remember as a dentist or as a professional who is providing root canal treatment, we are always made to learn that what we are treating is root canals. But actually, this is not correct. What we need to understand that we are not treating root canals, we are treating something called as root canal system, which comprises of lateral branches, which comprises of anastomosis, which we cannot see. So the major weapon that we have in our hand to eradicate microorganisms from the root canal system is disinfection, irrigation. So please do not take a shortcut from irrigation. Irrigate as much as you can. It might even take care of our bad obturations or any missed canals some of the times if we are lucky. Now, in cases like these, which clearly show a short obturation, definitely we know why teeth primary root canal treatment fails. But there are certain cases like these which are good looking obturations. They also fail. So this does not mean that if the obturation is good looking on a radiograph, the teeth treatment cannot fail. Patient can still be complaining. In this case, RCT is done few months back. Patient is complaining of hot and cold sensitivity, and patient is uh, pointing at a specific tooth, you know. So, and she is definitely very sure that which tooth is causing the trouble, and she is having hot and cold sensitivity and not tenderness to percussion. So this means the complaint of the patient clearly shows that there is a presence of biological tissue here. It can be within the obturated canals. It can be a missed canal. We really do not know. But yes, what we know is because of the complaint of the patient, there is a presence of biological tissue. And in this case, we are actually talking about the first molar. We are not talking about the premolar, which is seen with short obturation here. Surprisingly, she doesn't have any complaint from short obturation, and the RCT has been done around few years back. So this is how teeth and body can react very funnily, right? So seeing this tooth, now when if we go by the evidence basically says that we should not be doing any sensibility testing on a root canal treated tooth. It's a big no, as if we go by the evidence. But the patient is already having sensitivity, so every day she is having vitality and sensibility testing done. So if even if I do a sensibility testing with my EPT or cold and hot test, it will not cause any invasive procedure to her or damage to her. So I decide to go ahead with it, and to my surprise, I get a positive response. That confirms my observation when what I have listened to the patient's complaint. So always think out of the box. This is another point I would like to tell all of you, that if you are not doing any harm to the patient, you are not causing any invasive procedure which is irreversible in nature, then please testify the complaint of the patient. Once you are convinced, then we can move ahead. You can move ahead with your treatment. So now once I know that the tooth is complaining and patient is right that this is the specific tooth, I send the patient for CBCT, which because it's an excellent diagnostic tool, right? So it is not necessary to send every patient for CBCT, but it is important to choose your patients wisely, which should go for CBCT and which are more than enough to be seen under magnification. But in this case, because obturations were really nicely done, so it was a good idea to confirm on CBCT whether we are looking at a missed canal or we are looking at something within the treated canals, right? So when I sent this for a CBCT, you can see if my arrow is pointing, you can see a missed canal. So now what is the approach? When I have confirmed the missed canal here, two approaches I can take. One is either I will retreat the whole obturation, or I will go with something called as selective root canal treatment. And I go ahead with selective root canal treatment because I do not want to touch the whole root canal obturations because they are nicely done. Only a little sealer is beyond the apex, which I will not be able to take it out, right? I will not be able to take out the sealer. So why to disturb the full root canal? Let me try first to search the missed canal because I have confirmed the presence of missed canal there. So what we do is we basically make a small excess cavity in the mesiobuccal area because CBCT has confirmed the presence of missed canal in that CBCT, in that mesial area, in the area of mesiobuccal 1 and mesiobuccal 2. So a small excess cavity is made, and then with a DG16 Explorer, we try to search for a soft point, which can be the orifice. And here luck was in my favor. So we could find the soft point within 5 to 7 minutes of making a small excess cavity. The moment we find a soft point, a 10K file or a 15K file is placed inside, and it is radiograph is taken and the presence of a canal is verified. Only thing we need to take care here is when we take out the file, we need to see that if there is any presence of sealer on the file or gutta percha, because if sealer or gutta percha is present on the file, then depending upon the location of the remnants, then this means that that particular point file is touching at a GP or a sealer, which means that it is combining with each other. MB1 and MB2 are combining with each other, right? They are meeting each other. So that will testify your observation. So if there is no sealer or GP on the file, then directly this means that they are not meeting each other. Once you have verified on the radiograph, you can see on the radiograph they are not meeting each other. Use apex locator to have a working length. And if apex locator shows a proper working length, then directly this means that there is a separate canal and not meeting with each other. Once it is done, apex locator has verified, this becomes a simple root canal treatment for me. This doesn't remain a retreatment for me because I'm not retreating the complete tooth. And you can see in the video that I am just using rotary like a normal tooth because it's a separate canal. If it was a canal which is meeting, I can do two things. Either I take out the obturation of the main canal and treat them, both of them, as new canals, or I only verify to what length I am using my file in the MB2 and I take care of that length so that I don't hamper the GP in the meeting point. So here I am using irrigating profusely. I am using the rotary file systems as per the protocol. I really do not need to worry about anything because it's just a new canal I am treating and we are not doing any rocket science here. This is normally what we do as a dental specialist and performing root canal treatments. Irrigation, as I always say, if we are worried about the effect of sodium hypochlorite on the gutta percha or sealer of the already obturated canals, we can use a low concentration sodium hypochlorite. We should be using low concentration sodium hypochlorite, but leaving it for a longer period of time in the root canal. So once this is done, apply sealer. We can see here that bioceramic sealer injectable form is being placed inside the root canal. Basically, I am not very fond of using pasting the sealer with files and GPs because I feel that we are not able to do 100% justification or proper pasting of sealers. So I like filling the root canals with the sealer using injectable sealers and then placing the GP and sharing it off at the orifice. Now, GPs should be cut at the orifice. Pulpal floor should not be having GPs or a bed of gutta percha. Once this is done, you cut the GP and you can see on the X-ray, root canal is completed. MB2 has been obturated. Patient is completely fine. No complaint of pain, no complaint of sensitivity anymore, and the root canal has been taken care of. So this is one case that shows us that how we can actually confirm our observations and how we can actually take care of small steps in a retreatment and make retreatment easier for us, right? So another thing I would like to say here is, for me, this treatment is not basically a retreatment. This treatment basically becomes a C treatment. That is, I call this as a C concept, which means CRCT rather than re-RCT, because I am doing a corrective root canal treatment. I am not doing a complete re-root canal treatment. I am just correcting a mistake and I am rectifying that mistake and making the tooth successful by following the protocol. So we need to understand a subtle difference between re-root canal and C root canal. So in my terminology, I call such treatments as corrective root canal treatment because it makes very easier for me to understand that I just have to correct the mistake. Now, when we are making excess cavity in a treatment or a retreatment case, if we talk about a primary endodontic treatment, when we make an excess cavity, this is what we do. We basically take a burr inside, feel a drop, and then we do a lateral cutting so that we are able to find all the canal orifices. Once we have made an excess cavity, complete excess cavity, that is when we place our endodontic explorer inside, find a catch, and then we take our 10K or 15K file inside, depending upon the width of the canal, to check for canal patency. These are the simple steps that we use. What goes wrong then? Where do we go wrong? Sometimes what happens when there are calcified canals or calcified pulp chambers? We are not able to locate one of the canals, and that is when our heart says that it is somewhere here, and we use high speed to find the canal. Still, we are not able to find. Again, our heart says somewhere here. I have found distal canal. Me buccal canals are here somewhere. Let me go a little more deeper. And that is when we cut the tooth in every direction. And that is when we get something. I call it as a red carpet welcome. But that is we are welcomed by blood. Ideally, please understand that we should not be touching the pulpal floor. Once you have felt the drop where your burr has dropped down, after that, we do not need to do vertical cutting. We should only do lateral cutting. If you do vertical cutting, you will definitely end up touching the pulpal floor. In case you want to touch the pulpal floor, to find extra canals, you use ultrasonics. You can use peri-ultrasonics also because they will cut slow. They will cut at specific location, and you can use ultrasonic without any water because patient is under LA, he's anesthetized, he's not complaining of any pain. And don't worry about the heat. Ultrasonics do not create that much of heat that will damage the PDL. So you can use peri-ultrasonics and modify the excess cavity and find the calcified canals. Now, if you see this case has been badly touched, referred for if something can be done. And what we see here is a big perforation. But it is very important to read a radiograph carefully. When we say read a radiograph carefully, this means that either you start from the coronal aspect and read till the apical aspect, or you start with the apical aspect and go till the coronal aspect, but read the radiograph in a sequence. So let's see how we read it all together, right? So if we see here, somebody has digged deep in the distal canal, somebody has not been able to locate the mesial canals, and if I plan to go inside this tooth, what I will find first is one is perforation. Second is that I will find a overhang in this area where mesial canals are missed. And then in the end, somewhere there is periapical lesion. And if I am able to locate the canals and I feel it can, no vertical crack is there or something is not there, I feel it can be saved, then I will take care of the perforation. Because perforation is lying there for the last 3 to 4 weeks. So 1 or 2 days more will not make much of a difference here clinically if we talk about. So if now when we go inside the tooth, as I have told you, that there is a overhang present, verifying the obturation which you can see on the screen, oh sorry, verifying the perforation which you can see on the screen, and verifying the overhang which I have marked with the probe, and it is right coinciding with our observation in the X-ray. So once the overhang is seen, we need to modify the overhang, take the wall a little more mesial so that we are able to locate the canal. And for that, if we are able to see even with loops, that is great. Use a endo Z burr, which is a non-end cutting burr, and place the burr right at the point of overhang, not at the pulpal floor. It is already perforated. We don't need to touch the pulpal floor. And when we cut it, you can see here that it has been moved and the canals are located. You see here, I'm locating the canals with the probe, and you see how far is the perforation. You can see that red tissue there. How far is the perforation? So I'm not worried about the perforation at this point of time because it is too much far. Let's locate the canals. Once the canals are located, now I have a choice. Either I close the perforation immediately with MTA and then I do the root canal treatment, or I do the root canal treatment in a single visit and then I do the perforation repair. Both ways are correct, provided when if I take the option 2 of treating the root canal first and then doing perforation repair, there should not be a big gap between my root canal treatment and perforation repair. It should be around 1 to 2 days, and that's enough. Because as I already said, the perforation which is lying there for 4 to 5 weeks will not make a difference in 2 days' time. And if I use option 1, that I repair the perforation first, then what can happen is if I'm not using magnification, I might touch MTA with my files, which will actually cause micro cracks and micro leakage in the MTA. And if I use a strong full concentration sodium hypochlorite, then it can discolor my MTA also, right? So I decide to go ahead with option 2, where I do a root canal treatment first and then I do the MTA repair, because once the obturation is done, I am free to place MTA throughout the pulpal floor, seal the floor, make a new floor with MTA, then GIC, and then go ahead with doing the composite filling and crowning that particular thing. But be careful that we do not need to touch. So we start with the distal canals here. I start with a normal rotary endodontic protocol, taking care that I do not touch the perforation. Second is that we do not use full concentration of sodium hypochlorite. If we use full concentration of sodium hypochlorite, it might be toxic in the tissues of the perforation site. So please take care that use low concentration, because when we are using sodium hypochlorite, the game is not about the concentration. The game is about the amount of time you have left the sodium hypochlorite in the canal. So if you are using a low concentration, use it accordingly for a longer period of time rather than using it for a shorter period of time with full concentration or a higher concentration. So this is how we just clean all the root canals. And then, as I said, I use bioceramic sealers, injectable. I place the sealer. It also verifies confluencing canals in case of distal hair. Surprisingly, mesial canals were not meeting with each other, not confluencing, but distal canals were confluencing with each other. And you can see that I'm applying sealer in the canals. I always say that when you are treating one canal or obturating one canal, obturate or treat it in a way that the second canal doesn't even come to know what is happening. So that can only happen if you can see clearly with the help of loops or microscopes, and you follow a proper protocol and have patience with you, have time with you while doing such treatments. Then you can see I'm sharing off the GP here. I generally call this as stress-free and mess-free endodontics, because I am not creating a mess here. Sealer is not everywhere on the tooth. I am just placing sealer inside the canal, and I am using small steps to fulfill my treatment. Nicely placing a sealer with patience, with time in my hand. Even if my four patients are sitting outside, if I know that four patients are sitting outside, I will close the tooth there and then, and I will not go ahead with obturation. But if I have planned this, I know that I have kept good 1 hour for that patient, and I will do it properly with every step. Otherwise, if I do this treatment in a hurry, I will make a mistake 100%. So once this is done, then it comes the time of doing a perforation repair. And to do perforation repair, we use a very common material called as MTA, and we use MAP system to place MTA, which we call as microapical plug system. And it's an excellent investment if you want to do, because why I'm saying is that it is stainless steel. It does not go anywhere. It doesn't break. It is non-consumable. If you are able to take care of this apparatus, it is an excellent apparatus to invest in, because if you buy it today and you take good care of it for 10 years, it will work for you for 10 years. If you take good care of it for 20 years, it will work for you for 20 years. It comes like this. Assembly is this, with a piston to push, with a plastic needle, and a clean stainless steel needle to clean after application of MTA, so that MTA doesn't block this needle. It is a very simple system to use and very easy to clean and maintain. So I really like this system. So if you guys are interested in, please go ahead and invest in this system. Right. If you are interested in placing MTA in vital pulp caps or in perforation repairs, mix MTA as per manufacturer's instructions. And I, for my obturations and mixing sealers, if I have to mix sealer or these cements, I use something called as plano. This means that plan your obturations. You can see on plano clearly some marks are there, MB1, MB2, palatal, because what happens is I have seen with myself, if I place GPs after trial in on the table and I say this is mesiobuccal 1, mesiobuccal 2, palatal, distal, distobuccal, when I have to obturate, I get confused sometimes. Maybe because of hurry or lack of concentration, I get confused. So what I do is now I use plano, fill these sockets with sodium hypochlorite, place the GP of this canal in a respective slot so that I don't have to worry. And it also has a mixing pad here where I can mix sealer and cements like you are seeing, and then it is autoclavable. So it is again a one-time investment and it is not that expensive also. Here I am using MTA. I'm picking MTA with microapical plug system, map system, and you can see these kind of pellets will come out. Pick up MTA and now place MTA with the help of this map system gun, or we call it as MTA gun. I don't have to worry where I'm placing MTA. I will just throw MTA here. Only thing I have to take care is that we should not be pushing MTA in the periapical area. Just be careful that don't push MTA in the periapical area because we don't need it there. There is no harm. It's an excellent material, biocompatible material, but do we really need it? Because we are just pushing excess material just because it's biocompatible. We don't really need that, right? So just try to control your pressure, be a passive root canal specialist rather than being an aggressive and active root canal specialist. Place MTA, condense gently, and this is how the pulpal floor is built with MTA. After that, protect this MTA with GIC and then build it with composite. And you can see this is done here, but retreatments or these corrective root canal treatments are never complete without a recall. And you can see this immediate post-op and 10-week post-op already showing healing happening. And soon I will post this case with a good recall because I have a latest recall with me, which is again showing good healing. And now we'll be going for the crown here and it will be definitely perfectly healing, right? We had postponed the crown because patient had already invested so much of money. Patient didn't want to go ahead with the crown if healing is not there. So we are seeing a fast healing here. Thankfully only the patient was instructed that kindly take care of any excessive stress on this tooth because it should not fracture after so much of hard work. So thankfully it has not fractured till now, and we soon will be putting a crown on it and posting it on the social media after the complete healing is done. Now another important aspect is once you make excess cavity, yes, we have find the canals, but what is important is we need to have a straight line access cavity. If we do not have a straight line access cavity, this is what can happen. And instrument fracture or instrument separation is one of the most dreadful, incidents in clinic. And I generally call it as a 2-minute silence episode because once this fractures and X-ray comes, then we take some time to either tell the patient. Many of us maybe not be telling the patient, but ideally we should tell the patient, and if possible we should refer the patient for instrument fracture to somebody else, because good news is that these can be done. Instrument removals can be done. So if patient understands, well and good, but many of my colleagues tell me that you don't know about India, but my answer is that I have come from India only, I have practiced there only. So anywhere in the world, we should be telling the patient that this has happened, but don't worry. It can be taken out. We'll refer you to a good specialist and, then however it goes. If it is possible in your area, then it's really nice. We have good articles on it from the master Yoshi Teruhachi. He can take instruments in any part of the root canal or even beyond the root canal in the periapical area. But however, it is important to have a straight line access, because if we do not have a straight line access, or if we do not do any pre-flaring of the root canal orifice, then this is what can happen. Instruments are angulated. Stress will happen at the mouth, at the orifice of the root canal. Instrument is angulated, so ledge can form and strip perforation can happen, or it can fracture. So please pre-flare your root canal orifices, have a straight line axis so that your instruments go straight. They don't encounter stress at the very opening of the root canal, and they can reach the working length with subsequent cleaning and shaping protocol. But if we go through some articles, it clearly tells us that the instrument separation rate is really high, and it generally happens because the instrument gets engaged in the root canal, which we all know that this happens. So it is really important to have a good glide path first, have a good canal patency, so that you know how the canal feels like. We can use a 10K file or we can use a 15K file for canal patency, so that once we know how the canal feels like, we can actually choose our rotary systems and then use them. So when we say choose our rotary system, the choice of rotary system to be used does not depend upon us, that, okay, we have one rotary system, we will do all the root canals. It will never happen, because no system is the best system in the world. So the choice of root canal systems basically depends upon the type of root canals you are handling. If it's a curved canal, use a flexible system. If it's a straight canal, you can still have a liberty of using some stiff system. The most common teeth where root canals fracture is molars, and that too mandibular molars, because it is really difficult to access the mesial canals of mandibular molars. So I'll show you what you can actually do in the clinic to access mandibular mesial canals in a mandibular molar. But the good news of this article is that it tells us that we have ways of removing the instruments these days. If so, you people are interested, we do master classes, we do endodontic workshops for advanced endodontic master classes to take out instruments, to do perforation repairs. So if you guys are really interested, you can always get in touch and finish these do these courses and do learn about perforation repair and instrument removals. Now, I was saying that mandibular mesial canals are most difficult to access because the patient's mouth is open, our hand is going inside. We have to take the file from the back side towards the mesial canal, which is not that easy. So this is what I do, which you will see on the screen. This is what I do to access the mesial canals. I see, have a good look in the mouth mirror. Then I hold my instrument with a locking tweezer. You know, we all know what is a locking tweezer. So hold the instrument, pre-curve the instrument, and direct the instrument in a way that the pre-curved part of the file tip faces towards the mesial canals, and then with that tweezer, take your file to that particular canal, distal, mesial, whichever, so that you are seeing. Once the file goes inside, then use your hand, not a problem at all, because now you know where your file has gone. And this is how you can do the canal patency also. If you feel that this is applicable, please go ahead and do it and try in your clinic, because I know that this is very much applicable to be done. Only thing is we need a little training to see in the mirror and and have some patience with us. That's it. But this is applicable, so you can modify your treatment protocol a little bit here and there as per your need. And this is what we call as clinical experience. This is how we gain clinical experience. Again, moving towards stress-free and mess-free endodontics. So when we talk about separated instrument retrieval, these are basically done in two phases, which is a preparation phase and a retrieval phase. Preparation phase basically says that first the instrument should be visible, then it should be accessible to you. Then you should adapt the ultrasonics near the instrument to make space around it. And then loosening of the instrument should happen. And once the instrument is loose and dances in the canal, that is when we need to remove. For example, this patient was referred for root canal treatment because the colleague could not find the uh, root canals after attempting a excess cavity in this tooth. Now, when root canal was attempted here, excess cavity was made, the pulp chamber looks to be calcified. So, if I try to get inside the tooth, what we will encounter is we will encounter a calcified pulp chamber rather than feeling a drop. So, calcified pulp chamber means that we need to go slow and I will have to modify the excess cavity. And when we make a straight line access cavity, we basically follow the outside wall of the pulp chamber to make a straight line access cavity. And that is how we use our high speed instrument. So now when we go inside this tooth, you can see the initial access cavity. Now this cavity needs to be modified. So as I said before, either we can use endo-ultrasonics. I generally use endo-ultrasonics to modify the excess cavity, but I understand if we do not have endo-ultrasonics, that does not mean that we cannot use peri-ultrasonics. You can use, see here, patient is under local anesthesia. I have no issues. Patient is comfortable. I am using peri-ultrasonics without water for demonstration purposes. Patient is not feeling the pain. It doesn't produce that much of heat and you can use without water. Do not use this with water because if you use this with water, what will happen is your visibility will be hampered. You can see now that I'll be using with water and when I use with water, the water splashes on the mirror and I am not able to see anything. So kindly use peri-ultrasonics without water. You can see on the screen now water is coming and I'm not able to see anything. Though it is not going on the mirror because I have placed my suction properly, but still I'm not able to see. So I go back to my endo-ultrasonic and start modifying as I generally do. Once this is modified, I attempt a straight line access. It is made. You can see a radiograph here where straight line access has been made. And in my practice, I do not reuse my instruments at all. Why I am saying you will understand. I do not reuse my instruments at all in my practice. So whenever I'm doing a root canal, I'm using a brand new packet of instrument. I'm opening a new pack, doing the root canal treatment, throwing. Sometimes if the mesial canals are tight or some canals are tight, like in this case, I do not even use the same instrument in the second canal, and I mean it when I'm saying it, right? So when I use this instrument, made the straight line access cavity, now, when I open a new set of instrument and place my S1 file and I instrument the canal till whatever point of resistance I do, when I take out the file, it comes half out and you can see that the instrument is fractured. I'm surprised. A new instrument has fractured. I really do not know how it has fractured. So I go back to the X-ray, read the X-ray and see that how it has happened. What I understood was from this X-ray, I only followed the outside wall of the pulp chamber. However, the inside wall, which is green in color here, is also very high. So this means it is causing resistance to my file direction inside. So what I should have done was I should have definitely taken care of doing a little bit of more pre-flaring rather than doing a normal pre-flaring so that my inner wall also would have been widened enough to allow my instrument to go inside straight in the canal. So when manufacturers say that the instrument has triangular in cross section, we should actually trust them. You can see here directly that the instruments are triangular in cross section. By this, I don't mean to say that we start breaking the instrument inside the canal to see the cross section, right? But yes, they are triangular in cross section. So the first step to remove instrument from a root canal is we need to enlarge the coronal part of the root canal either with a GG drill or a wider rotary file till the head of the instrument separation. Enlarge it slowly. Don't be aggressive. It should be a passive movement, pressureless technique. Use a GG drill, adequate number 2, 3, whatever the size of root canal is, and pre-flare the part of the root canal coronal to the instrument because we need to have a straight access to the instrument. Once the instrument is completely visible, that is when we start our preparation phase of second stage of preparation phase. Once this is pre-flared, irrigate nicely. You can see here I am using some irrigation needles which are plastic. These are called as Irriflex needles or they also come as True Anatomy needles from Dentsply. Excellent needles. They are flexible, take the shape of the canal, and actually irrigant comes in two direction here because they have two slits. Once this is done, then we use our endo ultrasonics, but we need to have clear visibility either with loops or with microscope depending upon where the instrument is. But I'll show you that with loops also instruments can come out. I'll show you in coming slides. So once you use endo ultrasonics, just be careful. Do not touch the endo ultrasonics with your instrument, because if endo ultrasonic touches with endodontic instrument, heat will be produced and abrasion will happen and instrument can fracture further inside the root canal. Your endo ultrasonic can fracture, the same fractured instrument can also fracture. So just be careful. Do not touch the endodontic ultra instrument enough in the root canal. Once this is done, reconfirm the status of the instrument. The instrument should be loose inside the canal. When we say that the instrument should be loose inside the canal, this means that if you are moving the instrument with a probe from one side to other side, it should not come back to its original position. That is called as a dancing instrument. If it comes back to its original position, this means it is stuck in the apical part, and then still the instrument is not ready for retrieval. So please be careful that the instrument should be completely loose. And once the instrument is completely loose, we can use a BTR pen, which is basically from Circamed, and it is a very handy tool to remove the instrument. Catch the instrument because it is loose now, hold it from the neck with the loop, tighten the loop around it, and pull out the instrument. It is like fishing. We generally in our dental language, we call it as fishing the instrument. And the instrument is out. And once the instrument is out, I have corrected the mistake. It becomes a normal root canal for me again, right? So it doesn't remain a retreatment. It generally becomes a corrective root canal treatment here. So once this is out, locate all the canals, four canals in a calcified pulp chamber. In calcified narrow canals, we have found four canals, and the patient who came like this was obturated, preoperative radiograph. We made it like this. Here I can say I made it like this. Instrument fractured, but then ultimately when the mishap was corrected, this was the final result. So a mistake doesn't remain a mistake if you learn from it and you progress further. Root canal is done, patient is happy, and patient was told here that instrument has fractured, but do not worry, we will take it out. Nothing to worry here. So once this is done, patient is happy, and as I said, retrieval can be done with loops also. It is not necessary that you have to use only microscopes. If you are using loops, there are certain level of instruments which can be taken out mainly from the coronal and middle part of the root canal where the instruments are visible. You can loosen the instrument, use your loops, and then you can finish the instrument retrieval procedure. So it actually can be done. I just don't speak anything for the heck of speaking. If I'm speaking something, this means that I have tried it and then I am bringing on a platform. So it can be done provided we want to do it. That's a simple logic I believe in. Retreatment cases can be taken care of by reading the radiographs, removal of restoration, location of GP, then removal of Gataparcha. We also use these days a new file system, which we call it as a retreat system. If you guys want, you can actually click a picture of this slide because this is a new system that has been launched in India and there is only one dealer for this system. It's an excellent system which we have made with a company because what in retreatment we used to face was that we use H files, solvents, then we use rotary retreatment files, and then we use a separate set of shaping files. What we have done is we have brought a system which has a configuration of H file, which has a configuration of shaping files and retreatment files in one set so that you don't have to invest in two sets. The best thing is that the price is also less, and you can directly start with rotary GP removal rather than using solvents and everything. And this system is basically called as Retreaty. You can search on Google. It is called as Retreaty, and it has been made with a collaboration of Style Italiano Endodontics with Perfect Endo. And they have only one dealer in India as of now. So it's called as Retreaty, and you can actually Google this system and you will come to know more of that. In the end, take office message here is, please understand case is important, but please have patience when you are doing endo. You cannot do endo in hurry. We all make mistakes. I will also make a mistake. Give attention to every detail. Reading the radiograph, read your radiograph carefully. Spend time in reading your radiograph carefully, because if we hurry, we miss on the details, and that is when mishap happens. Mishap word itself says if you miss something, it will happen. So please plan your retreatments carefully. And if you do not understand anything, read again, question yourself or question your mentor or colleague. In the end, I would just like to say, see this video, a little music, if you are able to hear, that we all know that we are sitting on a weak stem and we do not know where to go. Sometimes instruments fracture the high communication. We say we feel that it is very easy to say, but I have gone through everything. So understand, if we want to do it, we will always be able to do it. Nobody can stop us from taking a jump and expand our wings, because the sky is open to all and every second is a new opportunity to learn. Please understand, we just need to get a little uncomfortable, come out of our comfort zone and try to do things to learn. These are my active social media accounts, where you can always, you're more than welcome to learn from cases which I post. If you feel that they are worth learning, or you can even follow it. And if you have any queries, I'm more than happy to answer those queries. These are the two books. You want to go through it, they are available on Amazon, they are available on Wiley Blackwell, and they are books which have clinical cases which you can relate day to day. And with this, I would like to thank Dr. Shanu for creating such a platform and giving me a chance to come over here and share my thoughts. I really hope this was helpful, and I really hope that I get to see more success in retreatment, and people get motivated to do more of retreatment and save teeth. Thank you so much, guys. Thank you so much, Dr. Shanu, for your time and platform.
Thank you so much, sir. So we'll try to have a question answer session. So I would request the audience to please post your questions which is relevant to the topic only, not any other topic.
Dr. Shifana, if I may answer, sorry, it's right in front of me. That's why I'm saying. Dr. Shifana has asked once more that instrument retrieval name, sir. It's called as BTR pen. It's from Circamed. It is called as BTR pen.
Yes, sir. So let's see if any questions are available.
Either everybody has understood or I have been too boring.
No, sir, definitely it's an outstanding class. We really appreciate your valuable time, sir, actually.
No, no, thank you so much. It's okay. That's fine. And we are here for teaching only. Because
Yes,
I firmly believe that if one can do it, then everybody can do it. I
yes, sir.
firmly believe that. We just stop ourselves because of some reasons, or we feel that one puzzle pieces are together, then I will move ahead. But this doesn't happen. We just need to move ahead.
Uh,
So if there are any questions, I am ready to answer. Otherwise,
okay.
you can post it on my social media. It's okay. I'll answer there also.
Yes, sir. So I think there's one question.
Yeah,
So
please.
with which ultrasonics can be used to remove the file even if we don't have a BTR pen?
See, you can use instrument removal ultrasonics. They do come from woodpecker, from densefly. instrument retrieval ultrasonics do come. Earlier, there were no BTR pens. Earlier, there were no, such instruments. So ultrasonics were only used. So you can use ultrasonics from woodpecker or from dense ply. Ultrasonic tips do come. Instrument retrieval ultrasonic tips.
So there's a question regarding about the file going beyond the apex. So what is your thoughts on that? Is it
See, we definitely, it's not a good idea to for the file to go beyond the apex or to leave the file there. However, if the patient is not complaining anything, no symptoms are there, then just obturate it nicely, disinfect as much as you can, and obturate it nicely. Have a good apical seal, have a good coronal seal, and then keep it under watch. Don't leave the patient hanging. Just keep it under watch, and definitely you will see. I have cases with me where instrument have gone beyond from some colleagues, and we could not retrieve it. There are cases which we have been lucky enough to retrieve from the periapical area also, either with BTR pen or with some three-dimensional files called as endoshapers from FKG. But not all instruments come. You really need to be lucky for that. But once this happens, leave the instrument there, keep it under watch, and if you have done a good root canal with good irrigation and patient is asymptomatic, you high chances you will see a good healing.
is there any specific endo tips to purchase for doing ultrasonics?
You can, as I said, there are excess opening tips, endodontic ultrasonic excess opening kits are there. There are endodontic ultrasonic instrument removal kits are there. So you can just name these kits as I'm saying, and you will see various options from woodpecker, from dense ply, from Spartan, from Optura. So many things are there. So you can always go and buy those depending upon the budget.
So there's one questions regarding about vertical root fracture. What are the chances of vertical root fracture in retreatment, sir?
It all depends how much tooth structure you have, how much pericervical dentine you have, how much dentine you have in the root. It all depends on that. But yes, if there is a metallic post there and you see a J-shaped lesion, which is a typical sign of a vertical root fracture, then yes, do not go ahead with retreatments. Choose your cases wisely.
So there are some questions which are out of topic. So please do ask questions which is relevant topic only. We'll select only the questions which is relevant to topic.
Dr. Sahana has asked, I think, how to no, Dr. Meena has asked something which sealer we have to use. You can use AH plus, one of the best sealers, but I generally prefer using injectable sealers. Even AH plus comes in an injectable form, right? Because I have slides with me where sometimes later when we do certain presentations on anything, I might show you that when we think that we are pasting the sealer, right? It does not paste properly. So injectable sealer means they come like a disposable needle. You just press, which you had seen in my cases, that I just paste and like an intracanal medicament, like intracanal medicament goes, it sealer also goes like that. So you can use those injectable sealers.
So what is the
Dancing
difference? Yes, sir.
Yeah,
Instrument dancing and
dancing.
flexing.
Sorry, it's coming in front of me. So dancing instrument means that the instrument is completely loose. Flexing instrument it means that it is going to the one direction. It is flexing itself, but coming back once you remove the probe. So if it is coming back, this means that instrument is stuck in the apical area somewhere. So we need to make it more loose by giving vibrations or ultrasonic vibrations, and then it becomes totally loose, and it is called as dancing instrument.
So I guess we will wind up this session, sir, because if any other questions are there regarding about the topic, we'll try to answer them in the social media platform. Why not,
No
sir?
issues there. My social media is right in front of you guys. You can click a picture and follow me there and just post your questions. Don't worry.
You,
I might reply a little later because sometimes we are traveling, sometimes we are somewhere busy. But then definitely I'll give a reply.
So thank you so much, sir, for sharing your knowledge and expertise when it comes towards managing the retreatment protocols. So
Thank you
surely,
so much.
surely many of us would leave this discussion with amazing takeaway points and implement techniques as per discussed.
Thank you
And
so much.
yes, sir. So thanks to all the doctors for patient listening and your participation for this webinar. And I hope all of you will depart this session with positive, confident manner. So once again, thank you so much, sir.
Most welcome. Thank you, guys. Thank you for joining.
Yes, sir. So it was a wonderful and informative session. And please do check out our sir's Instagram page where you can appreciate his clinical works and to know more about our upcoming webinars and workshops. Please do check out our website, which is iadpe.org, and you can follow our Instagram and Facebook pages as well. And if anybody has missed our previous webinars, please do check out our YouTube channel as well. And we really appreciate if you could subscribe. So thank you all and have a great night.